The following podcast is part of a certified educational activity titled Clinical Consults on Modern AML Therapy, where precision care meets potent therapeutics. Access the entire activity and complete the post-test at peerview.com/GXY860. Downloadable slides and practice aids are also available.
Hello, everyone. Welcome to Clinical Consults on Modern AML Therapy, where precision care meets potent therapeutics. My name is Dr. Gail Robos. I'm a professor of medicine and director of the leukemia program at Weill Cornell Medicine in New York City. And I am very happy to be here with some of my favorite panelists, Jessica Altman, Naval Daver, and Amir Fathi. And together we are going to guide you through a whirlwind of AML data and cases and questions. So let me launch into the bulk of our content. So the shape of AML therapy before 2017 wasn't a lot going on. There aren't very many boxes on this slide. So you were either fit or unfit for intensive chemotherapy, and lots of discussion of fit and unfit, but it was basically more or less a death sentence for patients to be in the unfit category, because the remission rates and overall survival with single agent hypomethylating agents, best supportive care, or hospice are obviously very limited. And those patients really had very poor outcomes. For the fit patients, we tried to come up with stratification by risk using cytogenetics and then molecular genetics into kind of good, bad, and medium categories, favorable risk, intermediate, and unfavorable, with really the goal for the majority of patients outside of the favorable risk category to go to allogeneic stem cell transplant. But then things changed, and actually starting in 2017, we started having a little bit more fun, because there had been multiple drug approvals resulting in significant changes in outcomes across the spectrum of AML patients, from younger, older, more fit, less fit. And you can see here a list of the FDA approvals, as well as one FLT3 inhibitor, quizartinib, which is approved in Japan. But looking at CPX-351, midostaurin, gilteritinib, ivosidenib, enasidenib, gemtuzumab came back, venetoclax, oral azacitidine, and glasdegib. That's a mouthful of drugs which we're going to go through in the symposium today to talk to the audience about how they're used, how we're using them, and what we see for further development. I would like to emphasize, to be consistent also with all of the major meetings this year, that we want to emphasize clinical trials and access to all populations across ethnic and socioeconomic groups to make sure that everybody has access to the best possible therapy. So for today's agenda, we're going to talk about cases. I think everybody learns best when they hear cases. So these are from our practices, case-based sessions on AML. We're going to talk about upfront therapy in high risk and mutation-defined disease, options for post-remission therapy, and strategies and next steps in developing targeted approaches for relapse disease. So let's launch into it, tracing the arc of novel upfront options in AML, customizing therapy. And I am going to launch into a case. So this is a challenging high-risk AML subtype. We have Mark, a 60-year-old man presenting with hypertension and diabetes. Symptoms include fatigue, night sweats, and myalgias, with a good performance status and 32% blasts, with an MDS panel showing a complex karyotype. And I'm going to toss it to my colleague, Naval. I think you're going to take us through some data that we need in order to make the best decision for Mark.
All right. Yeah, thank you very much, Gail. Pleasure to be here. And so this is, of course, one of the very difficult cases that we unfortunately see quite often in our practice, all of us. And so this is a patient, 60-year-old, with adverse cytogenetic features, otherwise seems to be reasonably fit, healthy, no severe comorbidities or organ dysfunction based on what we know. So in fact, there is a drug that was specifically tried and showed success in this population. This is an agent called CPX-351. It is a cytotoxic chemotherapy-based approach. CPX is a liposomal formulation of two agents that we've used for more than 4 decades now in AML, cytarabine and anthracycline guanorubicin. And the benefit of the liposomal encapsulation is that it allows better bone marrow penetration and also seems to have less GI penetration and side effects. And you see here a timeline of development relatively rapid development of this agent in a span of about 6 to 7 years, going from the phase 1/2 to the phase 3, which led to its eventual approval. So looking at some of the data, we have initially, most of us are familiar with, and there has been presented data showing that CPX351, when compared to 7+3 randomized phase 3 study, showed improvement in overall survival, which is the primary endpoint, also showed improvement in CR/CRi rate and reduction in 60-day mortality. So all the important parameters showed CPX351 was better than 3+7 in such a youngish patient fit for intensive chemotherapy. Now, I think this data to me has been quite impressive, where we have 5-year follow-up in AML population, which itself is quite rare. And what you see is with a prolonged follow-up, not only did CPX continue to maintain an overall survival advantage, but even in the patients who were transplanted, there was a clear survival benefit. And as you can see here with the 5-year follow-up, more than 50% of these traditionally very high risk adverse AML people were alive with CPX351 versus only about 25% with 7+3. So this data to me has kind of made me more encouraged with the benefit and potency of CPX351 in this population. What was also seen is that patients who are younger, and when we say younger here, we have to be careful because this population was only patients 60 to 75 years of age. That was the study intended population. But even among that, in the 60 to 69, which were the younger of that population, you can see that in this subset analysis, so not really powered when the phase 3 was done, but there can be a survival benefit that was seen. And what if you got a patient, gave them CPX351 induction followed by 2-3 consolidations, and then for whatever reason he could not make it to transplant? Did you do the right thing? And the subset analysis again suggests that even without transplant, CPX351 seemed to have a benefit. This may be because of the higher CR/CRi rate and lower early mortality, even without transplant. So I think for this patient, this would definitely be one of the good options for us to consider. So what are the key points from a practical approach? This drug has now been on the market for about 3-4 years. All of us have used it quite a bit. The key thing is it is approved actually for patients above 18 who have therapy-related AML or AML with MDS-related cytogenetic changes. It's important to note that there's one subset that we all are struggling to find a breakthrough agent in, and we don't yet have an answer. That is post-myeloproliferative diseases, AML. And unfortunately, that population was excluded from this study, so we cannot claim yet whether CPX will work there or not, and trials are ongoing looking at that. And then when in the phase 3 pivotal study, when it was compared to 3+7, the key highlights were it was overall better tolerated. The GI side effects, especially in hair loss, were less, which is very important for many patients, and lower 30 and 60-day mortality, improved CR/CRi, and the primary endpoint was overall survival. Now, all that being said, this is not a low intensity approach, and I think one has to be very careful when we use this agent. This does cause prolonged neutropenia, thrombocytopenia. We do see neutropenic infections in a similar rate to 3+7. So it's a better version than 3+7 for therapy-related secondary AML, but it should still be considered intensive therapy. And so whatever you would do for intensive chemotherapy, I would probably use the same approaches for the 3+7. And I think most important from the last year was the 5-year survival data showing that patients who got CPX with and without transplant did better at 5 years, and especially those who got CPX and made it to transplant, more than 50% were alive at 5 years, which is really very encouraging. So then what else is happening? This is some of the data that was presented at the ASCO meeting in 2021. Here you can see now as we're doing with everything else, and you'll hear this theme emerging again and again through the meeting and through our discussion, is that we're looking for next stage combinations. So now CPX is good. Can we make it better? Let's add a FLT3 inhibitor. Let's add an IDH inhibitor. And of course, the drug that seems to be highly effective in AML, let's add venetoclax. And this is ongoing. This was just showing that there's feasibility. It seemed to be tolerated, and we'll get more updates, I'm sure, in the next years as this combination proceeds. So now moving to venetoclax and HMA, which I think is the obvious other agent or combination that we could consider for this high-risk AML. So as a very quick background, this is the overall survival that was seen in the phase 3 study called the VIALE-A study. Azacitidine venetoclax versus azacitidine alone was powered for overall survival, and CR/CRh was another key endpoint. And what was seen was there was a significant improvement in overall survival, 15 versus 9.5 months. And more importantly, even at 1.5, 2 years, we see that there's a plateau. It's important to remember that these patients were actually different from the CPX. These were patients 75 years of age and above. So really that what almost everybody would consider truly older AML, or patients who had a very significant documented cardiac, pulmonary, or renal comorbidity. So not somebody where you just felt, oh, they're 65 and I'm concerned, but really somebody with a major comorbidity who would have had a high induction mortality and was really unfit for intensive chemotherapy. But even in that setting, improved overall survival, we're seeing some durability, and tumor lysis was seen, but a very, very low rate. Of course, this study implemented all the tumor lysis prophylaxis, and that's why it was probably well tolerated. Here is the overall data with the HMA-VEN. This is a subset that was pulled out in the secondary and therapy-related AML population. And what you can see is that even in those patients who had secondary AML, we see high remission rates overall. 67% was the overall response rate. And in those who had poor cytogenetics and those who were 75 years of age or older, pretty much maintained CR/CR rate in the range of 60 to 65%. And this is a theme we have seen again and again with HMA-VEN, that in most subsets, at least when we look at remission rates, it seems to be quite well maintained and makes it a comfortable choice to be used in the upfront setting. Now, survival, there may be differences we're seeing in different molecular cytogenetic subsets, but at least for remission, this seems to be a good option. And the key take home from here, so this is an agent that has been FDA approved based on the phase 3 in patients either 75 years of age or above, or those below 75 with a documented clear comorbidity making them at high risk, unfit for intensive therapy. It includes patients who have prior untreated MDS or AML MDS related cytogenetic changes. Again here, no data in MPN transformed to AML or previously treated MDS. So there is some small data sets in that, but not in this big study. Those patients were not included. Overall, this regimen has been very, very well tolerated. Early mortality in the range of 5 to 6%. It has shown very high remission rates. However, neutropenia is a common theme we have seen with venetoclax in this and many other combinations. So there is a learning curve to using venetoclax, and one has to really assess the response early. Most of us are recommending an early bone marrow end of cycle 1, and then using that to decide if we can hold venetoclax, use growth factors, allow count recovery. But I think with a little bit of experience and knowledge of the drug, this definitely has been a major game changer in the therapy of the older AML population, and responses are generally quite quick. So, Gail, do you want to turn it over?
Yeah, no, I think that was a perfect intro, and it kind of gives us what do we need to know to make the decision here. So if we think about this patient, so 60 years old, hypertension and diabetes, he has some symptoms, and we heard about the AML, which has an MDS panel showing a complex karyotype. So let me just toss it first to Jessica. So what do you look at? What more information would you want to know clinically? And how are you going to make a decision for this patient using whether it's CPX, HMA-VEN, or whatever else we didn't think of that's on your mind?
Sure. Thanks, Gail. It's great to be here. I think the most important thing is the determination if the patient is stable to wait for additional information. And we now have a lot of comfort compared to where we were years ago that we can wait for a complete characterization of a patient's leukemia prior to the initiation of treatment, except for patients, right, who are presenting with high white blood cell count and concern for leukostasis. So this is a patient where I would be really interested in knowing what the mutational profile is. I would like to ensure that the patient does not have a P53 mutation as I'm trying to think about treatment, and likewise would want to make sure the patient does not have a FLT3 or IDH mutation. Those are less likely in this patient presentation, but can be seen. So those are the things that I would be looking for. Assuming the patient does not have a P53 mutation, based really on the post-transplant data and a patient who otherwise appears to be fit for stem cell transplant, my primary consideration to start with in my initial treatment would likely be CPX-351.
And in Boston, the faraway land of Boston, what's happening over there?
Well, thank you so much for having me, and thank you, Gail. I agree with Jessica. You know, I think part of the challenge we have here is that there is a dearth of data for patients with you know, secondary AML, P53 mutated AML. We have some options. We know that CPX-351 is better than 7 and 3, and I think most of us would probably use that in an induction eligible patient. But we don't know whether ven-HMA, either ven with decitabine or azacitidine, would have similar efficacy when compared to CPX-351. We know that it's efficacious, but we don't have head-to-head comparisons, so we do not know. I do agree it's very important to know whether this patient has a P53 mutation, and the likelihood of it, I would say, is pretty high. In which case, the data is even a bit more shaky, right? So the data that Naval showed was not clear in terms of whether these patients who were transplanted had or did not have P53 mutations. And the data from ven-HMA studies to date have shown fairly decent response rates, but the survival and its duration have not been as impressive as other patients. So that introduces more difficulty in my eye. I think certainly the robustness of the patient does matter quite a bit. So I do agree. Most scenarios that we face like this one, we end up using liposomal daunorubicin and cytarabine.
So I would think, so this is what happens when the chair gives over control of the slides, is that one of you guys, who will be harmed later by me, advanced already to the reimagining of Mark's case and the TP53, and we'll get there in a minute. But before we actually talk about that scenario, I want to drill in one point, which is that, I mean, if you think about it, maybe I'm being in a philosophical mood about earlier in my career, but we saw a slide with really tough AML patients on a 5-year curve. That x-axis went out way beyond 6 months or 9 months. I think that Naval did a good job in presenting the fact that that's impressive. We don't get to see 5-year anything happening in a lot of data sets for AML, and especially in this group. And I think the other thing is the importance of what appears to be the CR benefit, even in those patients who did not end up going to a stem cell transplant, because we all know that we may imagine from day one that Mark looks terrific and is going on to a stem cell transplant afterwards, but perhaps that's not how the induction goes. Maybe there's a fungal infection, maybe something else happens. And I'm going to talk a little bit later in the show about what are the post-remission options. But I think having two very different therapies that are possibilities for this patient is quite an extraordinary improvement. I think there is a lot of debate which one to use, but I think having 5-year outcome data is actually quite compelling. And I would agree with the comments that you all made in terms of leaning in that direction. Now, because Trigger Happy over there got us to this next slide, I think Jessica's point was, okay, well, what about the difficult land of TP53? Having an MDS panel with MDS-related mutations could be a complex karyotype patient with a TP53 mutation. And I think we have all been worried about those patients with basically all existing therapies. So I will turn over the deck back to you, Naval, for a minute to talk to us about what might be new for this difficult group.
Yeah, so great points. I didn't pull the trigger. I'll just say that before we move on. But no, I think the 5-year data really does need to be highlighted. That's very, very impressive. Also shows the importance of transplant. I know we've all discussed transplant, no transplant. I actually think, at least in our experience, and I know others have mentioned the same, we're sending the same or even more people to transplant, and we're seeing how important transplant really is with effective therapy. So good points. But the TP53, of course, is the big problem child. And let's say if this patient had TP53. So Amir brought up some of those questions that we'll try to address. Actually, there is good data set. The data isn't good, but we have the data in both of these subsets. So this is with HMA-VEN, 2 different studies. The one on top is the phase 1b study, which had about 30 patients with TP53. And as you can see, even though the remission rates are a little lower, but not bad, 55% or so CR/CRi, the survival is dramatically different. I mean, you can put a thumb between those 2 survival curves. And then we at MD Anderson said, well, maybe let's try DAC 10-day. There was a lot of excitement with this in TP53, and that plus venetoclax, could this be a home run? And unfortunately, in TP53 at least, that was not the case. With both of these studies, CR/CRi 55% or so, not bad, but median survival 5 to 6 months flat. And as you can see, there's no tail to that curve at 1 year. So HMA-VEN, yes, if you have nothing else, try to take them to transplant, but in reality, this is kind of what was seen by both those studies. Now, what about CPX? Could we overcome TP53? And unfortunately, that is not what we have seen. Even in with CPX, TP53 mutated, the median survival did drop into that 5-6 month range. So really nothing breaking that 6-7 month barrier so far. In the non-TP53, clearly CPX doing better than 7+3, and even TP53, it did maybe better, definitely not worse. You could try it, but I think we're all looking for better options there. So one of the drugs among the two that are being developed for this is using a different form of immune modality called CD47 SERP alpha inhibition. And the goal here is to try to unleash the macrophages by blocking the inhibitory interaction between CD47 on the cancer cell and SERP alpha on the macrophage. So really conceptually similar to PD-1, PD-L1 story, but instead of T cells, we're trying to here activate macrophages, and the activated macrophages, it is hoped, will go and then phagocytize and kill leukemia or lymphoma or other tumors. And this has now led to the phase 1b/2 study, which now has also led to 2 phase 3 studies looking at this combination of HMA magrolimab in frontline older AML. And the study initially actually was for all older unfit AML, very similar to the HMA venetoclax story. But over time, we started seeing some interesting and high response rates in the TP53 mutated AML. As you can see, the response rate was close to 65-70%, which is quite encouraging. And the safety, and I think this is really the key factor with this agent, that it's very well tolerated. You don't see prolonged neutropenia, thrombocytopenia, early mortality, which tends to be a problem in TP53 because they're already cytopenic, was low. And so it looks encouraging. And at this time, this may be one of the approaches. Is a randomized phase 3 study that has started looking at HMA magro versus investigator choice, either HMA ven or intensive chemo for TP53 AML. And we will see what that study shows us. And with that, I will turn it back to you, Gail. Thank you.
Yeah, I mean, I don't think I'm going to get anybody on the panel saying that we don't want something better for TP53 mutated patients. We are happy to get some of them in remission, and certainly with this, we're happy to see the CR rates looking good. We need to see that OS data. I think we have all felt the pain of that before, that unfortunately there is something different about TP53 mutated disease, and that OS, that overall survival, is what we need to see. And I think it will be hopefully data that are forthcoming quite quickly to let us know whether this is going to be the new kid on the block. But I'm going to switch actually to the next portion of the symposium, which is going to talk about IDH mutations. So here we're going to talk about a patient who's 72, history of hypertension, AFib, fatigue, and progressive thrombocytopenia and neutropenia. She has a pretty good overall performance status and comes in with a normal karyotype, but additional testing showing an IDH1 mutation. I'm going to throw out there that actually I think in talking to colleagues in lots of different types of practices and around the world, these data are actually coming back faster. A lot of our previous discussions had been that the next generation sequencing is taking a week or 2 weeks or 3 weeks. You can actually get IDH by PCR now in a lot of places. There are a lot of places where you can get a FLIT, an NPM1, and a PCR back quickly. So things are getting better, and you might actually have these data right away, as Jessica pointed out, waiting, but maybe you don't have to wait that long. So I'm going to toss it then to you, Jessica, no, I'm tossing it to Amir. Who gets this one? I forgot. You do, Amir. Jessica. Amir does. Amir gets the IDH section, and take us through the data that we need to solve this case.
Thank you so much, Gail. IDH mutated AML is one of those areas that is perhaps becoming more clear in terms of our therapeutic options as opposed to P53 mutated AML. So the outlook is a little bit more optimistic, which is great. Here we have some of the options for patients who have IDH mutated AML, either IDH1 or IDH2, according to the NCCN guidelines for individuals over the age of 60. It's interesting that the case chosen for this particular set of slides was a patient who was 72 years old and a performance status and comorbidity status which wasn't particularly clear. I think in this patient, if we assume that the comorbidity is quite prominent, we could choose to pursue certain low-intensity options, especially if we think, as Dr. Dover was mentioning earlier, that the patient would not be, for whatever reason, suitable or appropriate for intensive chemotherapy. So the preferred options that are provided in the NCCN guidelines are ivosidenib for patients, that's approved, FDA approved, as an option for patients who are 75 years or older as monotherapy, or individuals who have substantial comorbidity. Another option in general for patients who are 75 years or older or not eligible for intensive therapy, regardless of mutational status, is venetoclax plus hypomethylating agents. And I will get to why this may be particularly apt or appropriate in patients who have IDH mutated disease. Other recommended options are hypomethylating agents. I would say that probably among my colleagues here and across the country, most of us probably don't use HMA monotherapy for individuals who have, older individuals who have AML, but there are scenarios where we may use it, but I would say more uncommonly. Also, venetoclax can be combined with other gentle options, such as low-dose cytarabine. That is also an option for older patients with AML. So let's move on and talk about ivosidenib, the IDH1 inhibitor. So as was previously mentioned, the last, 5 years or so has seen the advent all of a sudden of all these options for acute myeloid leukemia. Prior to that, it was a wasteland of very few options. Now we do have options. Among those are ivosidenib, the IDH1 inhibitor, enasidenib, the IDH2 inhibitor for IDH1 and IDH2 mutated patients respectively. Ivosidenib, the IDH1 inhibitor, was studied initially in prominently in patients with relapse refractory disease, but Dr. Robos and I think some of the other colleagues on this presentation were on the same study that also looked at newly diagnosed patients with IDH1 mutated AML and looked at ivosidenib as monotherapy. And as can be seen here in the bar graphs, had a fairly substantial composite remission if you count CR plus CRH in patients, in the fairly limited number of patients who had newly diagnosed IDH1 mutated AML, and the median overall survival was quite promising in these older patients of approximately 13 months. So a substantial number of patients who were older, many of whom had received prior HMA therapy, and again, fairly promising response rates and overall survival. So that came as welcome news. Shortly after the approval and increasing use of IDH1 and IDH2 inhibitor therapy in AML, people started to combine them with conventional backbones like hypomethylating agents. So there was an effort to combine both ivosidenib and enasidenib to azacitidine. This was a multi-arm study that looked at the combination of HMA and ivosidenib, and also looked at the combination of AZA and enasidenib, and then went on to do a randomization of AZA versus enasidenib plus azacitidine, looking at HMA combination options. And let's talk about azacitidine and ivosidenib first. I believe this was approximately 20-something patients in whom ivosidenib was combined with azacitidine in newly diagnosed IDH1 mutated AML. The overall response rate and the composite remission rate were quite impressive. Again, hovering in that 65 to 65% range for the composite remission rate, and also the overall response rate above 75%. The median duration of response was also quite good and was not reported to have been reached in the published paper. And there was substantial amount of MRD clearance in responding patients. And those patients who responded oftentimes, as you can see in the swimmer's plot, continued to respond for long periods of time. Intriguingly, the median time to response for this combination, as opposed to azacitidine and venetoclax, which Dr. Dover mentioned too, was longer. So the time to response for ven-HMA is around a month median. For this combination, it comes out to around 2 to 3 months. So you end up having to treat patients longer in order to achieve response. How about enasidenib, the IDH2 inhibitor plus azacitidine? Well, that was studied as well, fairly similar rates of response. And then there was an expansion randomization phase to the study, which compared enasidenib with azacitidine versus azacitidine alone. I think ultimately the impressive outcomes from this randomized study were the marked difference in overall response and composite remission rates, as can be seen here. Those who received the combination had higher rates of remission, higher rates of overall response. However, the overall survival did not differ between the two arms. Now, that may be related to the study design, the size of the cohorts, but it did not reach statistical significance. So this year at ASCO, Dr. DiNardo, Dr. Latchowitz, and colleagues from the MD Anderson are looking at various novel doublet and triplet options for IDH mutated AML, combining ivosidenib with venetoclax, or adding or not azacitidine as well. And as can be seen here with this reported data, fairly early evidence, but very impressive rates of composite remission, as can be seen in the bar graphs, whether venetoclax was combined with hypomethylating agents or whether the triplet was given, and the overall survival as shown on the right. Again, fairly impressive, although I assume all of us are waiting for a larger number of patients and larger studies to sort of hammer home the promise of these doublets and triplets. So, but this is where the future is headed, especially for drugs that are relatively well tolerated, such as IDH inhibitors. So we talked about well-tolerated options for older patients. Well, you can also paste IDH inhibitors through induction chemotherapy and study it. We did this, a large group of sites looked at the combination of enasidenib and ivosidenib with traditional 7+3 induction chemotherapy, followed by traditional consolidation. And I would say that the combinations were well tolerated, and the remission rates pretty much approximated what we have seen, I would say, in 7+3 alone, although this was not a head-to-head study, so we cannot say that the combination of IDH inhibitors with induction was better or worse. We can just say that it was well tolerated with a promising rate of response. But nevertheless, this was another combination that was looked at in the last few years. So we've talked about IDH inhibitors being well tolerated. Well, they are well tolerated, but I don't think any drug comes without any toxicity. So there were some non-hematologic toxicities. Some are listed here, such as GI toxicity, fatigue. But I would say that the unique toxicities of ivosidenib are QT prolongation. Of enasidenib is a form of indirect bilirubinemia that's typically benign. But for most IDH inhibitors, the challenging side effect profile is the onset of potentially lethal differentiation syndrome. Now, differentiation syndrome arises in about 10 to 20% of patients who are treated with IDH inhibitor. Typically arises 4 to 6 weeks after the initiation of treatment, but not always that duration. It might be sooner, it may be later. It may occur after stopping and resuming the drug, and it mainly manifests in a sort of a pleomorphic, vague, non-specific fashion that can be similar to the effects of pneumonia, cardiopulmonary compromise, the actual leukemia itself, and it can mimic them. So secondary causes we oftentimes try and rule out, but if the timing makes sense and we cannot rule them out quickly enough, we oftentimes end up treating differentiation syndrome. The symptoms and signs are typically pleural effusions, pulmonary infiltrates, hypoxia without those things, unexplained fever, rash, adenopathy, sometimes a bit of renal failure, weight gain. And the treatment that we generally use and we promptly start when we suspect it is dexamethasone, 10 milligrams twice daily. And then once the patients improve, and it should improve if this is indeed differentiation syndrome, a slow taper over time, and hopefully then a response that would follow, but that is not uniform. At the same time, if there are other secondary causes that we want to consider, we treat those as well, whether they are infectious, leukemic, or otherwise. So Dr. Dauber mentioned most of this, but just to talk about the potential role of the combination of venetoclax and azacitidine, or HMA therapy, in IDH mutated AML, this slide was already shown, basically the survival advantage and the marked improvement in outcomes in patients who received a combination of venetoclax and azacitidine versus azacitidine and placebo. But just to look at one of the other tables from that New England Journal paper, you can see that the group that seemed to do the most outstandingly with the combination of azacitidine and venetoclax, albeit this is subset analysis, were those individuals who had IDH mutations, as can be seen here. So that therefore means that for us, one potential option for a patient who is older, who is not deemed to be eligible for induction chemotherapy, might be venetoclax and azacitidine or decitabine therapy. This was another abstract also looking at subset analysis of IDH mutated patients from the Viali and other then HMA combination studies, again showing the composite remission rate of the combination versus AZA alone. It was marked, as was the overall survival advantage in this cohort of patients. So back to our case. So I'm going to toss it back to Gail so she can ask some questions and guide the panel.
Yeah, I mean, I think you did a terrific job going through those data. And I think that you said a couple of things that strike me. So the first is we all want to see more data so that we can actually make the choices, except we're not going to get it. And that reality drives me crazy. These are rare patients. There's no way that we can have randomized trials to make all of these decisions. And you've given me options, and I like options, but options are stressful because IDH inhibitors work well in IDH mutated patients, and venetoclax works well. And if you go to MD Anderson, you're going to get all of them together, and that works well. And I have this patient in my office, and I would like to know what to do with this 72-year-old patient. So first, Naval, what 12 drugs is she going to get if she's in your office?
Yeah, no, I think that's great to have options, right? And the problem here is the opposite of TP53. It's how much can you give just to maintain a great survival without going toxicity. So, I mean, what we're doing at Anderson on a clinical trial setting, right, is to see if you can add the IDH inhibitor to HMA-VEN. And I'd say among the many what we call triplet regimens, it's probably the one that's most easy tolerated. And I think that's because the IDH inhibitors don't have as much myelosuppression of their own. And so, I mean, I think that's the approach on a trial setting. I would try. Now, let's say it's a community doctor who's emailing or calling me and says, I'm not comfortable, I've never done that. Then I would probably say you have to choose one of the two. Now, most of the times, the molecular data may not be available yet, right? So the patient is there, day 3, bone marrow shows leukemia, 75-year-old, they don't want to give intensive chemo. My gut instinct would be, well, if you're comfortable, go ahead with HMA venetoclax. Let's start with that. There's a high remission rate. Amir showed survival is 3-4 years. When they relapse, we'll see what to do with the IDH. If you have the data, it's tricky. I mean, I'm almost a little bit more inclined towards the HMA IDH just because of the tolerability, the lack of neutropenia. But I think either way, one is not really going wrong with either of those doublets.
So one of the things that I think is emerging is MRD. So measurable residual disease is a topic of a lot of discussion, and it's both flow cytometry based, but of course in the molecularly defined subgroups, there are molecular possibilities of MRD, and you can have VAF reduction, you can have elimination of the clones. You can also look, of course, here in the clinical trial at some of the 2HG measurements. But here's my question. So ASCO is showing some data, meetings are showing increasingly data that MRD may matter for low intensity therapies. It may be important. We don't know actually for IDH inhibitors and for IDH mutated disease and for IDH1 in particular. I think it's not even entirely clear what type of VAF reduction would actually result in different outcomes in transplant. But we sort of have the sense that whether you are treating with a quote unquote intensive or a less intensive regimen, you are looking for some kind of disease clearance. So Jessica, I'm wondering, does that influence your decision tree in somebody? I mean, I made the case this hard deliberately, right? 72. So you might be transplanting this patient. Are you trying to drive down this disease molecularly? Are you just trying to get her into a normal count recovery? What's really the goal? And does that make you, does that really focus your decision at all on which agents to choose?
So I think phenomenal questions that you all tried to wrap up into one, and clearly there's a lot to unpack there. I think I want to first go back to, I think part of the question was, what would be our initial approach to treatment, and how does the potential for MRD clearance or disease clearance impact our decision making? So like Naval, I would likely, in the absence of a clinical trial, start probably with a doublet therapy. I'm a believer in patients who are not, who've made at least the initial decision that they are not going to proceed with stem cell transplant, to try to sequence agents and not give everything up front, to try to, at this point in time, I don't know that giving everything up front makes people live longer or better. So I try to sequence agents. So for a patient like this, who, if the decision after lots of discussion with a patient has decided at that moment to not proceed with stem cell transplant, I would likely give aza-ven followed by, at the time of either lack of further tolerance with persistent disease, or at the time of regrowth of disease, then proceed with my IDH inhibitor. And by then, given the median survival, we may have even more data about what appropriate combinatorial therapies are at the time. Now, for someone who is older, fit, but not interested in intensive induction chemotherapy after discussion of all of the treatments, I may offer a triplet-based therapy in the absence of a study, recognizing that there are some growing safety data, and then offer a stem cell transplant if the patient becomes fit or continues to be fit for transplant and is interested in that. Recognizing that there is an upfront risk of stem cell transplant, that in one's life may be shorter, and certainly one's life may be compromised in terms of quality of life. So I think a lot of conversation and a lot of discussion about goals and patients' values and how they weigh each of these potential outcomes.
So thank you, because then I don't have to say what you just said before asking Amir that, do your transplanters, are they going to want that follow-up PCR and or next-gen sequencing report saying that your IDH mutation is gone before going to transplant? Because I keep hearing that people are going for transplant consults and there is a non-zero number next to either the PCR or the next-gen, and then the patient is tossed back to the leukemia program. What's happening with your team?
I mean, just like what you said, I mean, I think the world is changing. It used to be, get this guy to me as close to 5% blasts as you possibly can, and I'll transplant this person. Now it's 0.0004%. What is this? Clean this up. I feel like it's when I went home from school with a report card of 1 A- and 5 A's. You know, it's so it's definitely changing. Now I do push back a little bit, because I say, you know, there is nothing here. There's absolutely no data for us to say this patient should not be transplanted. We know that if there is less MRD versus more MRD, people do worse or better. We know that. But there is nothing to say if I give this person 2 or 3 more cycles or change therapies that I'm going to make the situation better, especially with more resistant disease. So it becomes talk about challenging, it becomes more challenging. I would like to just echo what Jessica said. This is a real challenge with Ven-HMA. With induction, with Vyxeos 7 and 3, you kind of know when to check MRD, right? You give the treatment, counts come up, or in the case of CPX, it may take some time, but it comes up, and then you do the MRD analysis. Then HMA is tough. I mean, and you know, in terms of when do you check MRD? When are patients in the most optimal remission, deep remission status, to sort of know whether you can, you know, give credit, as much credit to the treatment as you possibly can. And that's difficult. But I do agree that checking MRD after the first cycle, when you have very little count recovery, is probably not the best time to sort of assess your depth of remission. You should wait until you have some count recovery.
Yeah, I think that it's worth kind of we want to make a few perhaps summary statements of several issues here, because I think that it is a very confusing time to figure out what to do with molecularly defined subsets. So let's talk about that for a second. You have the opportunity to treat your APL patients, right? That's a molecularly defined subset that's not on this webinar. That's on another webinar. But here we're talking about IDH patients, and let's just throw in, because we can, the NPM1 mutated patients as well. These are patients who can be followed by sequencing. They can be followed by PCR. In the IDH1 subsets in particular, you have actually x-axes on your survival curves that are looking past 2 years with HMA-Ven. With the HMA inhibitor combinations, you have long-term survival. I would call this long-term survival in older patients with well-tolerated agents, and you don't have transplant data, and I'm going to go over this in a minute, but telling me that there's an 80% cure rate at 2 years of anybody over 70, not even close. So I think we want to be careful in the whole MRD discussion about, first of all, this concept of hammering away at tiny numbers with the understanding that that number has to be driven to zero. I don't think anybody feels that way. There are no transplant data to suggest that if you go to 0 versus 1 times 10 to the minus something, we don't have those data. So we have to be careful about that. But in particular, we've also been talking about a subgroup of patients that's doing pretty well. So do we want to be transplanting those patients at all? And is that based on concomitant mutations? And I'm not sure, because I think there are ones in combination with IDH that change the story. I'm going to use that to segue myself, I think, into the post-remission zone, because we touched on a little bit, and I want to dig a little deeper. Is it multiple cycles of the same therapy that you start on that we should be thinking about? Are we still trying to get everybody to transplant? So what's happening in the post-remission space? So let's think about this case. This is Deborah. She's 65. Again, the hardest age, because I can put her into whichever side of the older, younger I feel like it, depending on my own age. She's got an NPM1 mutation, a DNMT3 R882. She's in good shape. She's got a little hypertension and diabetes. I don't know if it's a little or a lot. I didn't say in the case. Good performance status. And there's also a low allele ratio FLT3 ITD in there too. So the mutational profile is FLT3 low, NPM1, and a DNMT3 R882. What do we do for this patient? Does she get more of what? Is she a transplant candidate? Should we transplant her? Should we be doing oral azacitidine maintenance? Is there post-transplant maintenance? Lots of questions. So post-remission maintenance therapy in AML, there is definitely a very strong bias based on the world of AML that you can't just get somebody in remission and leave them after one cycle of anything, because usually those patients don't stay in remission. Sometimes every once in a while they do, but mostly not. And if you look here at, this is NCCN guidelines, if you look at the last bullet point, it's observation. If you look at the top one, it's allogeneic stem cell transplant. And you can do lots of different things in between. Allotransplant has historically been the goal for pretty much anyone who can get in an AML, because that's the only thing that is allegedly able to cure the disease. And it's not really allegedly up until now. And probably still through 2021, that's the only curative therapy that we have. You can do some consolidation chemotherapy, very controversial. What is good for consolidation and how many cycles are important? Lots of controversy, especially for patients over 60, whether intensive consolidation actually does anything. You can do intermediate doses. You can do intermediate doses of cytarabine along with inhibitors, for example, for FLT3 mutated disease. And then even after what is typically called a consolidation round, you can do maintenance. Maintenance usually refers to something that is lower intensity and different from what you've done before. In this case, we have oral azacitidine, which is approved for maintenance therapy, but there are also, there's a lot of clinical data supporting ongoing cycles of hypomethylating agents for patients who are either after chemotherapy or after transplant. So to unpack that a little bit, we used to try to get everybody into transplant, and I spent the entire first part of my career trying to urge people not to give up on patients, even up to 75 or 76 or even older than that, because you wanted to give fit patients in good shape a chance to have more than the mediocre overall survival that what we were offering them with single agent HMAs or with low dose cytarabine. But here, if you look again at my favorite word today seems to be x-axis, but if you look at how far it's going, this is the therapy that's being offered as cure. And yet on a good day, it was 40% on patients with disease-free survival at 2 years after transplant. And that was if things were going well. Usually you were not getting patients in an older age group out anywhere near 5 years. And certainly the relapse-related mortality as well as non-relapse mortality were substantial, and non-relapse mortality getting higher when patients had high comorbidity scores with multiple other medical problems at the time of their transplant. But this is what we had, so this is what we were trying to do. Now, What else is out there in terms of maintenance? So looking at Ratify was looking at the addition of midostaurin to chemotherapy. So we knew at the time already, as the study was evolving, we knew that FLT3 mutated patients weren't doing great with chemotherapy alone, and we were trying to get patients into transplant. But the study wasn't really designed to show definitively the power of midostaurin to result in a survival benefit. And basically what this shows is that, again, it's not perfect statistically, but it looked like maintenance with midostaurin was of benefit for FLT3 mutated patients. And this is both important for these actual patients and for midostaurin, but also conceptually, ongoing therapy in AML with something may be a good idea. The disease is still there at a low level. The immune system maybe can't clear it up. Maybe it's a good idea to have ongoing therapy. Now, in the FLT3 world, there are other drugs that have been investigated in the, in this case, post-transplant setting, looking, for example, at sorafenib. Sorafenib can be glitchy to use. A lot of people don't have that much experience with sorafenib, but there was a clear survival benefit with sorafenib in these FLT3 mutated patients. And actually, of interest, it's much more than just a FLT3 inhibitor. There are immunomodulatory aspects of sorafenib that may also play a role here that might be important. So again, thinking about FLT3 maintenance looks like it's important, but also thinking broadly, is ongoing therapy an important thing in AML? Is AML hypertension? If you take away your blood pressure pills, your blood pressure gets worse again. Is that possible that that is true for AML too? And you need ongoing therapy. It's a question, not an answer to a question. FLT3 also, we have newer agents, and just to give a shout to the trial that is ongoing, looking at gilteritinib versus placebo, is there a benefit? We think it looks like FLT3 mutated patients are benefiting from FLT3 maintenance, but which is the best drug to use, how long to use it, these are still open questions, and the clinical trials are obviously the perfect way to answer them. Now, again, what else can be done post-transplant? So think about it. This I think is mind-blowing for patients, that I'm going into a transplant to get cured. What are you talking about that you want to give me more therapy after my transplant? I'm supposed to walk on hot coals, get through this transplant. I got to move to Houston for several months, and then I have to do something else. Well, unfortunately, there are lots of patients who are entering stem cell transplant with disease that is very likely to relapse, either because it was detectable by flow, or because it's not fully in remission, or because it's a biological bad actor. We don't really know exactly what to do here. It looked like there was some early data that oral azacitidine in the post-HMA, stem cell transplant setting was looking pretty good, actually. And I think we are hoping that there will be more data to try to look at CC486 and to look at what actually to do in the post-transplant setting. Then we have some conflicting data in one study looking at no difference in RFS between patients randomized to azacitidine versus observation after transplant. But then another study, confusingly, in a phase 3 design, so showing that very low dose decitabine in combination with G-CSF actually did seem to have a benefit. So difficult to decide, but it is clear that there is at least a signal for patients going into transplant with biologically difficult disease that there may be an opportunity for post-transplant maintenance that still results in a survival benefit, and that's hopefully tolerable if it's in a kind of low intensity form. But what if you just can't even get to the transplant? So I'm talking about maintenance therapy now in the setting that's supposed to cure you. What if you can't get there? Well, there are lots of patients, actually. If you look at what's happening across the country and across the world, it is by far not the majority of AML patients who are getting a transplant. It's in fact a minority. At academic centers, the number tends to be higher, but actually very few patients overall, if you look at the schema of AML patients, are going to transplant. So what happens? Well, sometimes they don't want it, and sometimes they shouldn't get it because of disease-related factors or because of medical comorbidities. If you look at the QUASAR trial, which is CC486 or oral azacitidine, in this trial, there were patients with intermediate and poor risk cytogenetics who were older than 55 who couldn't go on to a transplant. So these are patients who got intensive chemotherapy, who were are in remission, but they're not going to a transplant. So you know that these patients have a high chance of relapsing, and they were randomized to CC486 versus placebo. We looked at these patients for a really long time and followed them for lots of different things, which is good because we have a lot of data coming out about what happened to them. But the most important slide, which led to the approval of the agent, was actually an overall survival benefit. And again, that nice x-axis, we're seeing data going out nicely beyond that 2-year and that 3-year mark. So all of a sudden you're thinking, well, wait a minute, these patients couldn't go on to transplant, but what if they could have, but they still got this drug? This study doesn't answer that question, but I think it brings up the opportunity for patients to consider that, okay, if I'm not getting transplant, what else can I do? This is something that can be done. The data here specifically for after intensive chemotherapy. Now, looking at, so is this tolerable? One of the reasons why maintenance, if you go all the way back to 1994, when kind of HIDAC was born, those patients actually got maintenance. Everybody forgot about that because it was low dose chemotherapy maintenance that was difficult to take, and patients didn't like it, and there wasn't an overall survival benefit. So it got kind of thrown away. Here, what we were able to show with lots of quality of life data and with lots of follow-up is that the adverse events were quite tolerable. Patients were able to stay on study for a very long period of time. There were some GI events primarily in the initial cycles, and there are some data suggesting that some patients figure out how to modify that toxicity, either by taking a little bit of Imodium or by taking whatever it is that's bothering them, taking something that is designed to mitigate toxicity. They get used to it and they didn't go off the study and they stayed on. The hematologic toxicities were very manageable, and the patients are able to stay on the treatment without a compromise in their quality of life, and that was tested throughout the study. So this is being updated now with there's a ton of data from the trial, and I just want to highlight a couple of things. So in this, the oral AZA, basically it reduced the risk of death regardless of the baseline characteristics. So there are things that are not favorable for AML patients. If you are MRD positive, if you have more advanced age, if you have poor cytogenetics, it doesn't change that. Those are associated with worse outcomes, but the oral azacitidine helped regardless, whether you were MRD positive going into the trial, whether you were in the older age category, whether you had the poor cytogenetics. It doesn't fix AML and make it better, but it was better for patients, even though in those less favorable subgroups. Here, these are recently at the EHA meeting disembargoed data that were presented on NPM1 mutated AML. And this actually is particularly interesting because the study showed that NPM1 mutated patients were behaving as they should. They were behaving in a generally prognostically better group, but actually even better when they got oral azacitidine. So it begs the question that are you going to take an upfront risk, for example, of transplantation in patients when you have some certainty or some reason to believe the patient could get out, beyond that 2-year mark? Might you kick the can for some patients and wait for a better therapy to go along rather than risk a transplant-related problem earlier on? So I think these are interesting data, and we hope to have more on different mutational subgroups. Now, what about, we just talked about it a lot, that venetoclax actually seems to do particularly well with NPM1 mutated patients. Well, what if we can take those patients and do things to those patients other than transplant? These are some interesting early data just showing that actually venetoclax can get rid of detectable NPM1. Might there be a role for ongoing therapies? Again, oral azacitidine already has looked good. What if you combined it with venetoclax? Might that be even better? This is not a suggestion to do this immediately. It's kind of forward looking of what might be coming down the road. So now we're going back to this patient, and this patient, again, by design, has lots of things going on that we just talked about. There is an NPM1 mutation, but there are also 2 concomitant mutations that make us a little bit less confident that the NPM1 is in a fully favorable category because she's got some FLT3. It's a low-level allele ratio, but it's there. And the DNMT3, although there are different types of DNMT3 mutations, the R882 ones give people a squiggly feeling that this is not generally a favorable, one this could be more aggressive. So I'm wondering, I want each of you to please comment on what would be, for this particular patient, what would be your plan? And maybe Naval, I'll start with you.
Yeah, sure. I mean, obviously, yeah, this patient has a lot going on, as you said. I do think that with DDNMT3, and even though it's a low burden FLT3, I would be concerned that this is not the traditional ELN favorable. I would start thinking this patient is going to behave more like an intermediate risk or even slightly higher given the R882. So if I could go to transplant, I think that would still be my inclination. If I could get a fully matched donor, the patient was in good condition, and transplanters are willing, we had good response, I think that would still be my first shot. Would I do FLT3 maintenance post-transplant? Today, I probably would. I'm hoping that the study that you showed, the randomized gilteritinib placebo study that's looking at MRD, both pre-transplant, post-transplant, and using that to decide, if somebody should get maintenance and should not get it, how long, will help us answer those questions. So I think that would still be the curative option if the patient denied or there's no donor or financial hurdles or she fell apart after intensive chemo, which we do see in 5 to 10% of patients. They just have poor PS, infection, sepsis, and they want to stop. Then I think, the CC486 would be a good option at this time as the long-term maintenance.
Jessica, what do you think?
Yeah, I really like Naval's comments. I agree, my goal for her, if she is interested after a conversation, my goal, I think, would be a stem cell transplant in first remission. I don't yet know if a FLT3 inhibitor post-transplant will have a benefit for her given her allelic ratio. So I think there's a little bit more to uncover there. I would still offer it to her. I just don't know that it will have a benefit.
So Amir, I'm going to make your life more difficult, and I'm going to tell you that she's the patient. She's going to have nice. Okay, that will be repaid shortly. That will be repaid shortly. I was going to go over everyone's full credentials and accolades, but now not yours. At any rate, what if I tell you that the patient is PCR negative for NPM1 and is undetectable? Her doctor checked everything and there's nothing detectable by sequencing, flow, or PCR.
So NPM1,
PCR negative, next gen negative, FLT3 is gone, DNMT3 is gone. Everything is gone. It just went away.
Well, somebody did a very good job. I still, you mentioned that uneasy, squiggly feeling. I think just looking at this, I would have that uneasy, squiggly feeling on multiple fronts from the beginning. So the FLT3, the DNMT3A, and I think for that patient, I would follow exactly what has been said in terms of what Jessica and Naval said in terms of trying to get the person to transplant. And we do proceed with FLT3 maintenance therapy following transplant. So I think regardless of the depth of remission, I would probably still do that given her age and the fact that I can't give her HIDEC, and intermediate dose RSC is, in my opinion, not as likely to sort of give her a chance with her NPM1 mutation. I would still probably move forward with transplant. But I would not fault anybody if they wanted to give a couple of cycles of consolidation and give oral azacitidine. I think the data is very strong, as you showed, in terms of trying to get these patients out. This patient cleared her NPM1. The data is very strong, as was presented by you and your colleagues recently. So I think that is also a very good option. But I think given the presence of the FLT3 and what I have seen in the past, ITD usually doesn't stand idly by, in my experience. At some point, it rears its ugly head. I know there is a relative lack of data there in terms of low allelic ratio, but that's still what I would do.
I want just one more question because I'm kind of curious myself. I said something bizarre, right? I said ongoing therapy for all of AML. AML is some kind of weird chronic disease with ongoing therapy forever. I mean, Naval, is that, we have well-tolerated drugs now. Should that be the goal, to just keep them, or what do we do to get patients off therapy? They're very expensive, and although they're well tolerated, is that a reasonable plan to have AML patients on indefinite therapy?
Yeah, I mean, I think really for the first time, there's a true discussion with patients with reasonable options on both sides. I mean, we always say this, but we always have in our mind something and we impinge that on the patients a little bit. But I think now this is a real discussion, right? And we have this very routinely in our meeting, even going to the frontline therapy for this patient, right? If you have a FLT3 mutation, NPM1D and NPM3A, let's say at Anderson, the first discussion would come, would I give this person aza-ven FLT3 inhibitor, right? Versus CPX versus three. And then the next question is, would I transplant? Would I use NPM1? And I think this is where we're really talking to patients. Look, we could give you intensive therapy. We could take you to transplant. We could do maintenance. Maybe it'll all be done in a year and a half. There's a lot of risk, GVHD. Or we could go the chronic route. There's no data. Nobody has 4-year. Or we could give you HMA, then FLT3 after a while, put you on HMA, FLT3. It'll be lifelong therapy. But hey, if you're alive in 5 years, that's a good lifelong therapy to have. So I think, at least personally to me, I think the general movement that we're pushing to is to make it a chronic disease, more like multiple myeloma, where there's less early mortality, less early toxicity. Maybe somehow transplant can be lower intensity, or in some people, even we can get away with it, but improve survival, quality of life, time outside hospital, move to oral medication. So that's, I think, where we want to go. That's kind of the goal. It will be expensive. I think that's one thing that we have to factor in later when we get to that point of 5-year survival. But yeah, that would be nice. Like you said, if we can make it a hypertension or multiple myeloma, maybe is an example kind of situation, I think I would be happy.
We're going to have to figure this out, because I do think a substantial proportion of patients conceptually, let me walk on hot coals, let me get transplanted, and let me be done. And I just, yeah. And I just think it's really hard. I think that part is really hard. And I think we are going to have to figure out what for which patients can we actually say that, or if they're going to be on chronic therapy anyway, to really identify the specific role of taking the risk for transplant. Amir, you want to say something?
Yeah. I just wanted to, one thing that I think may not have been mentioned, I think all of us have seen in maintenance studies, is the duration of maintenance. It's a bit all over the place depending on the maintenance trial you're looking at. You do 1 year, 2 year, indefinitely, as was mentioned. The same debate is with CML following transplanted patients. So I think that's another question that we need to figure out, whether indefinite therapy is necessary or not.
It's so hard. One of my patients, I think my patient on the Quasar study is the longest US patient still, and I don't know, we're like 8 years at this point, and she feels great. I feel great. Are we stopping therapy? So, to somebody with a dangerous disease who's doing well, are you gonna take it away? It's hard. But I want to move on, because we have lots of exciting things to cover. And I want to land in relapsed refractory AML, which everybody has always groaned when we get to this part of the discussion. But I think there is some cause for optimism. And we are going to hear from Jessica why we have any reason to be optimistic in the section of the talk that is usually the very difficult one. So, 55-year-old man with relapsed FLT3 mutated AML. He initially got 7+3 induction with Mido on days 822 per the ratified trial, and he got a CR. And then an allo, and then he didn't have midostaurin maintenance. And then post-transplant in remission for 9 months. Now he has a new onset of cytopenias, and the bone marrow shows a relapse, and he's got a FLT3 ITD again. So what are we going to do?
Thank you, Gail. I do agree that there is definitely optimism in relapsed and refractory AML, which we didn't see previously. And I think the first decision point in patients with relapsed and refractory disease is to determine if there is an appropriate target that we can go after. And so that's the first column that we see, versus if there is not an appropriate target. And the reason why it's targeted therapy first versus candidacy for intensive or aggressive therapy is based somewhat on some of the data that we'll be showing that targeted therapy has a survival advantage in some instances, even to the most aggressive therapies with the data that we currently have. And so what we mean by targeted therapies are the things that we've already alluded to. Is there the opportunity to target a FLT3 mutation or an IDH mutation? And then consideration of another semi-targeted therapy, GO, for CD33 positive disease, which is the majority of AML patients, And then the consideration is the next appropriate step, if there is not an appropriate target, an aggressive or a less aggressive approach. I'd like to focus our conversation on FLT3 inhibitors based on the nature of the case that Gail presented. We are in a world where we have midostaurin approved in combination with intensive chemotherapy for adults with newly diagnosed FLT3 mutated disease. Gilteritinib is approved in the United States for relapsed and refractory FLT3 mutated disease. Quizartinib is approved in Japan. And there have been studies in use of sorafenib outside in the context of clinical trials, both with aggressive intensive therapies in relapse disease in combination with HMA and in post-transplant data, which Gail already presented. And there are ongoing studies in multiple settings with crenolinib. Perhaps some of the most robust data that we have in relapse disease for FLT3 mutated patients is the Admiral study, with a recent update from ASCO this year, which confirms the improved survival with gilteritinib compared to salvage chemotherapy. Patients were allowed to receive either intensive salvage chemotherapy or less intensive salvage chemotherapy. And despite, regardless of which salvage chemotherapy was utilized, gilteritinib has a survival advantage compared to salvage chemotherapy in relapsed FLT3 mutated disease. But the question becomes, does that response carry over in patients who've had prior TKI exposure? Relatively few patients who were treated on the Admiral study had received prior TKIs, and that's just because of the nature of when those trials were done. Not as many patients had received midostaurin in combination with 7+3. And so there is a look at the data from both the Chrysalis and Admiral trials, which were the Astellas-sponsored studies, assessing the response rate to patients who had received prior TKI or who hadn't received prior TKI, and a multi-center retrospective analysis. I'm going to start with the second bullet point on this slide, which reviews the data from Chrysalis and Admiral, which were the Astellas-sponsored studies. And if you just go to the bottom line on the slide, for patients who had received prior tyrosine kinase inhibitors, the CRC rate was 45%, which compares fairly favorably to those who had not received prior TKI therapy. And likewise, when a multi-center retrospective review was conducted, we found very similar outcomes. So we looked at 13 centers we've reported thus far, and about 72 patients who had prior TKI exposure who received gilteritinib for relapsed and refractory FLT3 mutated disease. And when we look specifically at about 45 patients who had received 7+3 and midostaurin in the standard approved approach for those fit for intensive chemotherapy, the CRC rate was in the 50% range with a median survival of 7.8 months on this limited patient population, which compares fairly similarly to what we see from the Admiral data, which makes me feel, so with the data that we have available today, that gilteritinib continues to retain its activity in patients who've had prior TKI exposure. I think this is an important piece of information when we're counseling patients. We've mentioned quizartinib already, and I want to just point out this data that quizartinib shows survival advantage compared to salvage chemotherapy. This, however, has not been approved by the FDA, though is approved in Japan. When I think about FLT3 inhibitor use in adults with relapsed and refractory AML, I'd like to highlight a couple of points. Mutational testing is important in both newly diagnosed and relapsed and refractory disease. One cannot assume that the same mutational profile is present at all points in the disease course. As I mentioned, response to gilteritinib is seen even in adults with prior TKI exposure, and gilteritinib tends to be relatively well tolerated. However, it's important to know that we are still treating relapsed AML. So even though you're giving someone an oral agent, you cannot give them their prescription and turn your back on them. These are patients who still need the support that we would provide for folks with relapsed and refractory disease. So monitoring of blood counts, appropriate antimicrobial support, and transfusion support. There is the risk of differentiation syndrome with gilteritinib. It is less common and behaves a little differently than what we see with the IDH inhibitors. There have been reports of posterior reversible encephalopathy syndrome. Pancreatitis should be assessed if patients develop clinical symptoms of pancreatitis. Patients need monitoring of their liver function. And creatinine phosphokinase testing should be conducted. Patients may have CPK elevations. It very rarely results in clinically significant changes for our patients. Finally, there is a risk of QTc prolongation, and so EKGs are recommended prior to the initiation of therapy and on days 8 and 15 of the first cycle, and then at the start of the next 2 cycles. So gilteritinib is what we have that is the approved therapy for a patient like was presented to us. But I think we have a little bit of data regarding treatment beyond single agent tyrosine kinase inhibitors. And I want to move to a discussion of doublet and triplet based therapy. Naval and other colleagues of ours and I have been very interested in the development of venetoclax and gilteritinib combination for relapsed and refractory FLT3 mutated disease. And we presented an update of this data at EHA this year. Essentially, this was a trial for relapsed and refractory AML. The initial dose escalation cohorts allowed patients with both wild type and FLT3 mutated disease. We are obviously most interested in those with a FLT3 mutation. Patients were treated with venetoclax at standard dosing in combination with gilteritinib at the approved dosing in relapsed and refractory disease of 120 milligrams, with the primary outcome being a modified CRC rate, which this was utilized a little different from the International Working Group's CR rate, and essentially allows the inclusion of a morphologic leukemia-free state patient to really allow us to analyze the data in context to the Admiral data. I'm not going to go through the entire details of the study, but I want to note that for all patients with FLT3 mutated AML, the modified CRC rate was approaching 76%. This regimen is notable for significant cytopenias. However, those cytopenias are able to be modulated by dose interruptions and dose modifications, and resulted in an acceptable mortality rate at 30 and 60 days. The overall survival for those who had prior TKI use was 7.6 months, and the molecular response was assessed in this trial as well. So essentially, we looked at FLT3 burden of disease in the ITD patients, and a molecular response of under 10 to the minus 2 was achieved in 60% of our evaluable patients. But we don't stop there. So we have, that's our doublet data. There is also triplet data, and surprise, that data has been spearheaded by MD Anderson. It feels a little silly for me to be talking about Naval's data while he's sitting here with us, but I will do my best, and he will certainly comment as appropriate. So MD Anderson conducted a study for adults with both relapsed and refractory disease and newly diagnosed disease, the combination of decitabine, venetoclax, and quizartinib. And the data is shown here. The CRC rate in relapsed and refractory, because we will segue from relapsed and refractory to frontline therapy, the CRC rate is 70%. And in newly diagnosed patients, the CRC rate of 4 patients, but still very, very impressive, was 100%. And you can see that the median overall survival for those with newly diagnosed disease is not yet reached at a median follow-up of 7.2 months. And in the relapsed and refractory cohort, the median survival was 7.1 months. So in summary, mutational testing for patients with acute myeloid leukemia is required, in our opinion, at both diagnosis and relapse. Specifically related to FLT3 mutated disease, response to gilteritinib appears to be maintained even with those who have received prior midostaurin. And gilteritinib and venetoclax doublet appears effective in adults with relapsed and refractory FLT3 mutated disease. Triplet studies are being tested and the early results are very promising. We are not done in FLT3 mutated disease, and there are certainly questions that are on the horizon that we are all talking about. I personally am eagerly waiting follow-up for triplets based studies and additional studies ongoing and being planned in newly diagnosed patients. Just like we have the questions in IDH mutated patients, we don't yet know if it will be better to sequence agents or give all of our active agents at the same time. And some of this may be depend on the goals of the patient and the expectations of stem cell transplant or not. We're also very eager to be able to develop MRD as an appropriate surrogate in clinical trials to allow us to get to a response assessment sooner. And a looming question, if the data with triplet-based therapies in older adults is encouraging, one then wonders if FLT3 TKI-based therapy with HMA venetoclax could potentially replace a 7+3 and TKI approach. So Gail, can you lead us back through our case?
Yeah, so as we pick up the case, I mean, I think that we had really not been talking at all in relapse patients from any kind of survival beyond 3 months, 4 months, 5 months, and now we're at 7 and 8 for some of these patients. So it's not breaking the sound barrier yet. But the question is, how much can you, again, the concept of kick the can you get the patient back into remission long enough that you can then do something else? So for somebody like this is a 55-year-old man. This man has already had a transplant, right? So this is a post-transplant relapse. I think you were very, very clear that intensive chemotherapy in this setting is not going to be where we're going, but where are we going to be going? So in a post-transplant relapse in a 55-year-old, let me toss to Amir first. What are you thinking about for our patient, Alex?
Well, as of right now, the option for this patient with what appears to be a FLT3 mutated relapse disease is gilteritinib monotherapy. I mean, that's sort of the conventional approach for these patients. Now, what do I do in the clinic? I oftentimes combine it with HMA and get, in my experience, relatively robust rates of response and fairly good survival for my own patients. Now, the data regarding how these patients do in the randomized study is still, we're still awaiting that, and that's a question that needs to be answered. Now, is there room for improvement? Yes, I think there is definitely room for improvement over gilteritinib. Gilteritinib already moved the goalpost, and I think we are able to move it even farther down the field. I think that's great. I'm not sure if that analogy was correct, but I think you guys catch my drift. As opposed to doublets and triplets, I'm all for it. I do have some concerns, and I think Jessica alluded to this earlier, regarding marrow suppression and whether this is potentially going to be clinically challenging in older patient population, especially if that marrow suppression is prolonged. MLFS is fine. I just think that MLFS that lasts a long time or is recurrent ultimately and gets us into some trouble with fungal infections and neutropenic challenges and potential effects on outcomes. But the quizartinib data that was presented is also quite interesting, and I wonder if it seems like less MLFS, more CRI in that group, even though HMA was added, and I'd love to sort of look at that data in more granular fashion and see what the difference was. Perhaps there is a difference between gilteritinib and quizartinib in terms of its combination with venetoclax and how marrow suppressive it can be.
We're going to move into some questions, but before we get there, I need some love from either Naval or Jessica, whoever answers faster. I think sorafenib has magical properties in this setting. I have seen beautiful things happen with post-transplant relapse of FLT3 mutated AML using sorafenib, which is somehow a drug that doesn't fly into people's minds. Somebody talk to me for 5 seconds about sorafenib, and am I crazy? Did I just get lucky with it?
I'll let Jessica go. So we love that. I mean, I think for this patient, I mean, I think, I think what Amir said is great. I would probably go for the combo with, if I could, with Van adjusted, get count recovery. Sorafenib, am I really using in relapsed AML much today? No, with GIRT and on trials quiz available. I think in the post-transplant maintenance setting, is there something special about it? Possibly. I do think that that data with the T cell modulation is actually real. So it'll be interesting to see what the gilteritinib maintenance shows, because we all expect it to be poundingly positive and much better than sorafenib, and I hope it will be. But if it isn't, then I think we have to really go back to the drawing board and think of sorafenib as an immunomodulator post-transplant, and then maybe it'll work in even non-FLT3 maintenance post-transplant. So I think that study, the randomized bone marrow transplant study, will help guide us where to go next.
So let's move into some questions, because we actually have an opportunity to address some of the audience's specific questions. And I think that what we want to do is try to quickly both answer as many questions as possible and also offer a couple of summary points. So let me jump into a couple of specific ones. So let's just say in a therapy-related AML patient who's 60 or younger without comorbidities, Naval, would you give CPX-351 or a then HMA and then a transplant in both instances, regardless of the induction that you choose?
Yeah, so the second part is easier. 60-year-old therapy-related AML, absolutely, I would go for transplant. I think today, based on data we have, I'd probably be leaning more towards CPX-351. If HMA then with one of the other drugs that we're looking at in the future, whether it's magrolimab, pevonedostat, cusatuzumab, shows something, maybe that'll pull it up. But I think today the data would be CPX followed by transplant, maybe some form of post-transplant maintenance on a trial, and hope for long-term survival.
Okay, and one for Amir, are you using next generation sequencing for MRD monitoring? And are you using marrow or blood or both?
Well, again, the second part's easier. Typically, we use marrow for MRD analysis. MRD is still a bit unbaked as far as I'm concerned. I think most of us would agree. In certain scenarios, I feel has much utility. So if somebody has an NPM1 mutation, we talked about, you brought up the case of a patient who had lost their NPM1. Certainly in a younger patient who has lost their NPM1 after an induction and a cycle of consolidation, that gives me a lot of information about whether that patient should go to transplant or not. Similarly, with core binding factor and version 16.8.21, those nucleic acid studies, that MRD analysis also quite predictive and prognostic. Apart from that, it gets a little tricky. I think all of the data to date that I've seen, at least, seems to suggest that MRD analysis is highly prognostic, meaning that if it's there, it's bad. But as to what to do about it, whether to transplant these patients, when to transplant these patients, how to use it, it becomes a little bit tricky and it becomes challenging. I'll tell you, it's difficult in my clinic because we do MRD and patients come, at the time of remission. I say, congratulations, you're in remission, but you have MRD. And they say, well, what does that mean? And I say, well, it means it's worse than if you didn't have it. And then they ask me, well, what are you going to do about it? And then I don't look that smart anymore. So it becomes difficult in those types of situations. And the lone potential wrinkle to that is this notion of potentially incorporating HMA therapy in states of remission, looking at MRD to see whether you should start and stop treatment. We were talking about indefinite HMA-based therapy. There was a Lancet Oncology paper, I believe, that came out of Germany fairly recently that looked at that. That might have some potential utility in looking at MRD. The other challenge of MRD, and I'll stop talking after this, is there's many ways to measure MRD. So how do you do it? Do you do it by flow, NGS, looking at specific markers like IDH and FLT3? That leads to the confusion in AML, so that it's not as easy as, let's say, ALL.
It's not easy and it's complicated. And the only thing that I can do to offer some measure of de-confusion is that the updated ELN guidelines on MRD are actually on my computer awaiting my revisions. And we do hope to publish that soon. I think there are some significant updates that are going to be helpful in practice, and the area is very much evolving. And I think everyone on this panel will be cautioning the audience not to check next generation sequencing every 5 minutes in the blood and assume that that will tell you what to do, because it won't.
Gail, I think one other additional point is that most NGS I think it's important to know what the limit of detection of your NGS panel is. So some NGS panels will not report something as positive unless it's at 5% or more, that's clearly not a good MRD test. So I think we should make the distinction that there are some PCR, individual PCR testing that can be done for MRD analysis. In vivo Scribe, as a commercial shop, has FLT3 and NPM1 MRD. Some individual labs also will have PCR based for IDH and NPM1, FLT3, and the core binding factor gene products. And again, there's flow studies. So I think knowing the limits of detection of the pathology colleagues that you're working with is really important, especially in an area where we don't really know our best way of approaching MRD.
Yeah, I mean, I think that's a great comment by Jessica. I missed it. I mean, I think when we say NGS, we have to be careful about what we mean. The NGS panels that we use at our academic institutions are oftentimes not sufficient at all to really assess MRD. They're not that deep because it measures multiple different genes at different sensitivity levels. So we have to be thoughtful about that. There are specific NGS panels that are sort of created for the purposes of MRD analysis, and those in theory can be used. But again, as Gail mentioned, there are market limitations that perhaps soon will be better clarified.
And just to make, I mean, all that you see is not MRD, right? I mean, we have to think for the audience, things like DTA mutations. The other way is true too, that you may pick them up, but they may not be MRD. So I think I agree with Amir's statement that unlike ALL, where it's much clearer, much more homogeneous, you have an MRD razor, or it is good. Here we have a lot of different problems. So yeah.
We definitely do not want to end a symposium with a lot of problems, because that is a negative note to end. But I would like to make some closing comments that I just think that this has been an absolutely excellent and rich discussion. I personally think we could go on for a pretty long time discussing these cases, which are hard and which we have to solve in real time in clinic, and also to just hang out with each other and talk about things, because we are still in a virtual platform when we would rather be in a live studio or a live auditorium somewhere.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/GXY860. This activity is supported through educational grants from Bristol Myers Squibb, Jazz Pharmaceuticals Incorporated, and Servier Pharmaceuticals. This activity is accredited by Medical Learning Institute Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.